Welcome to PsyDactic. I'm Dr. O'Leary, and today is Thursday, May 15th, 2025. I host two podcasts. One is dedicated to general interest topics in psychology and psychiatry, and the other is supposed to be a resource for child and adolescent psychiatry fellows to help them learn their craft and to study for their boards. The music you are hearing in this episode was composed by me for the child and adolescent edition of this podcast family. I myself am a child and adolescent psychiatry fellow, so making this content especially helps me to study, and it's also a lot of fun. Sometimes I explore topics that fit well into both of the podcasts, so I'm going to release them into both. Today I'm exploring one of those topics, Pediatric Bipolar Disorder, and other things that could be confused with it, like Disruptive Mood Dysregulation Disorder. This topic is difficult and controversial, so please understand that my formulation of it is only one of many possible formulations, and my opinion reflects my own opinion only and not necessarily the opinion of anyone that I am talking about in the podcast, anyone that I work for or work with, just my own opinion. Now, I also extensively use AI more and more producing these podcasts. You may have met my AI co-hosts in previous episodes, but today I'm getting back into the driver's seat and hosting the content myself. One of the tools that I've used to put this together is Google Gemini's advanced deep research feature, and it can produce longer form content through a process that includes AI reasoning algorithms and a deep search through available digital content. I can also provide it with papers and YouTube scripts while it crawls around on the internet looking for other trustworthy sources of related information. It's a really powerful tool. Now, at the end of the show transcript, I have pasted what it produced for me and its own strategy for finding that content. Now, I also use my own knowledge and experience, of course. I'm not just entirely relying on AI, and I do spot check the sources just to make sure that it isn't making stuff up. But more and more, I find that AI tools are more reliable, accurate, and thorough than most humans are, at least at what they do. I can also ask it to be more thorough, and it will. I can ask it to focus on certain nuances, and it will. It doesn't have to have pre-existing knowledge in that to answer my question. It can go look for it. So to start talking about pediatric bipolar disorder, I want to start with a couple case vignettes. So the first one is about Leo. Now, Leo is a 9-year-old boy. He's referred by his pediatrician to a child psychiatrist due to extreme moodiness and uncontrolled temper. His parents report that for the past 18 months, he's been really irritable and on edge. And this is pretty much every day. Every once in a while, he seems to have some good days. He experiences intense temper outbursts about 4 to 5 times per week, and this is often triggered by really minor things, like being asked to do homework, or to turn off the video game, or to give them the tablet back. Now, during these outbursts, he screams, throws objects, and occasionally has hit his younger sister, though when he's not having these outbursts, he is not violent. Now, these episodes last about 20 to 30 minutes, every once in a while can extend to around an hour or two. But then he's sullen and angry for hours afterwards. Now, his mother notes that between the outbursts, he's also kind of quick to snap at them, and his friends often describe him as grumpy. I mean, the few friends that can tolerate him. The parents deny that there have been really any distinct episodes that they can think of where Leo seemed kind of unusually happy or silly, and he's always had some trouble sleeping. He takes a long time to fall asleep, but parents haven't noticed any change in that recently. There's no family history of bipolar disorder, but his father has a history of depression and anxiety, and his mother has a sibling with ADHD. Now, Leo denies any suicidal thoughts or clear depressive cognitions like worthlessness, though he admits to feeling kind of mad all the time and he doesn't know why. He describes within himself this monster that wants to come out all the time. Now, based on the information provided, and only that information, which of the following is the most likely diagnosis for Leo? A. Oppositional defiant disorder. B. Attention deficit hyperactivity disorder. C. Disruptive mood dysregulation disorder. Or D. Pediatric bipolar type 2 disorder. Now, the correct answer here, based on these criteria that you have, is disruptive mood dysregulation disorder. And let me explain. Leo's presentation is consistent with the criteria in the DSM. He has severe recurrent temper outbursts, and they're often grossly out of proportion. They also occur multiple times a week. The outbursts are inconsistent with his developmental level. At 9, he should be able to regulate himself better. And between these outbursts, he's persistently irritable and angry most of the day, most days, and other people notice this. Also, the symptoms have been present for 18 months, so longer than a year. And there has been no distinct period that met criteria for a manic or a hypomanic episode. I'm going to spend just a quick moment here to discuss why it's not oppositional defiant disorder. So while Leo shows oppositional behaviors, this argumentativeness, defiance, ODD is characterized by a pattern of argumentative defiant behavior and vindictiveness. But if DMDD criteria and ODD criteria are met, only DMDD should be diagnosed. And I don't think I have to explain why it's not ADHD, but I do want to mention that he could also have ADHD, and ADHD untreated especially can result in kind of some chronic irritability and oppositional type behaviors because of the psychosocial distress that they experience. But it's not the primary thing in this vignette. Now let's compare Leo with Maya. So Maya is a 15-year-old girl, and she was brought in by her aunt, with whom she lives and has lived for the past 3 years because of her parents' kind of acrimonious divorce and her mother's subsequent struggles with substance abuse. But Maya's always been kind of distractible and impulsive. She even has a 504 plan in school due to difficulty concentrating and finishing her work. She's never been worked up by a psychiatrist for this or for her primary care. She also finds it difficult to wind down at night and often doesn't fall asleep until about 1 a.m. But in the last month, Maya has begun to sleep frequently only 2 to 3 hours a night and still claims to feel kind of totally wired during the day. She's redecorated her room, she started writing a novel, and she also told her aunt that she was planning a charity fundraiser, but didn't complete any of these things, except the redecoration of her room. Her speech, it's always been a little rapid, but more recently it's kind of been difficult to follow, and at times seems to jump between topics. She also becomes irritable pretty quick when questioned or when her aunt tries to redirect her, and so this has led to several shouting matches, which her aunt thought at first was just like normal teenage rebelliousness. But she's also started spending more money online and maxed out a gift card that she had. And then she went to her aunt and asked for more money, stating that she had met this guy on Insta who has brilliant ideas that would make them rich. Her aunt also reports that Maya has been more kind of sexually suggestive in her on her online posts and talking to more guys. Prior to this month, Maya had some periods of being withdrawn and sad, but these the aunt thought were particularly around the anniversary of her parents' separation, but sometimes she had to miss school for a few days. Her mood was so low. She also has occasionally complained of scary memories of her parents' fights and has always avoided talking about her past. She has a history of above average grades, A's and B's mostly, but recently has been skipping a lot of classes and has an F in 2 classes. What is the most likely diagnosis for Maya? A. Post-traumatic stress disorder. B. ADHD. C. Pediatric bipolar disorder. Or D. An adjustment disorder with disturbance of conduct. Here, the correct answer is pediatric bipolar disorder. and her current episode is manic. I'll go into all of the reasons why this is the case soon, but I want to point out that she has had distinct period over the past month of abnormally elevated and expansive mood, feeling wired all the time, and irritability with persistent increase in her energy and a lot of goal-directed activities, along with a decreased need for sleep, pressured speech, flight of ideas, and some involvement in activities with a high potential for painful consequences. So like she's recklessly spending, she's a little bit more sexual and talking to a lot of guys online, something she didn't do before. Let's get in more to the nitty-gritty of what is pediatric bipolar disorder. At its core, pediatric bipolar is a chronic mood disorder in children and adolescents, and it's characterized by pronounced, often extreme shifts in mood, energy, activity levels, concentration, and really the ability to carry out everyday tasks at their developmental level, like they used to be able to carry out. So these aren't just like your typical childhood ups and downs. We're talking about distinct periods of mania or hypomania, or elevated or irritable moods, along with this increased, almost endless energy. And it can be, especially with bipolar type 2, interspersed with periods of depression, sadness, loss of interest, and also irritability, with decreased energy and motivation. So these episodes have to be a clear departure from the child's usual way of being, not merely just a response to active or recent stress. And they have to be more intense and persistent than just the typical developmental mood swings that a lot of kids have. So while bipolar is often diagnosed in adolescence and young adulthood, symptoms can emerge much earlier in childhood. And it's generally considered a lifelong condition once diagnosed, though some children diagnosed with bipolar will not have symptoms in adulthood. So let's talk specifically about the Diagnostic Bible, the DSM, and how it defines bipolar disorder. So the DSM encourages us to take a lifespan approach. So recognize that mental disorders can show up at different life stages, and that development plays a big role in how they look and appear at that different stage. So for some conditions, the DSM-5-TR's updated criteria to better capture kids' experiences. But really the golden rule here is that no diagnosis, pediatric bipolar disorder included, should ever be made without a thorough evaluation, especially considering parents and other caregivers as crucial information in the diagnosis. If the parent is saying the kid is irritable every single day, most of the day, but the teachers at school say the kid is very pleasant most of the day and is not an issue, so that's something you need to know. So don't diagnose bipolar just with one person's report. If there's conflicting information, look into that. For bipolar and related disorders, we generally use the same DSM diagnostic criteria for adults, children, and for adolescents. So that means we have to be like super up on what typical kid behavior is versus what is actual psychopathology. So there's this kind of constant tension and a lot of provider specific interpretation that's going on here. And this debate's been going around for a while. How does, or does even, bipolar disorder look different in kids? So let's talk first about bipolar 1 disorder according to the DSM. So bipolar 1 disorder is defined by having at least one lifetime manic episode. If you have had one episode, you have bipolar 1, that's it. You can have major depressive episodes in bipolar 1 as well, and they are common, but they're not required for the diagnosis in bipolar 1. They are required for the diagnosis in bipolar 2 disorder. Bipolar 1 requires manic, and a manic episode is a distinct period of abnormally and persistently elevated, expansive, or irritable mood, and abnormally and persistently increased goal-directed activity or energy. And it has to have been going on for at least 1 week, or any period of time if the child or adult has needed to be hospitalized because of the symptoms. So if the symptoms are very severe, you can call it manic, no matter how long it's been going on. And it needs to be present for most of the day, nearly every single day, in that period of time. During that period, there are some symptoms that we think of. One of the mnemonics used is dig fast, but here I'm just going to describe them. So you need an inflated self-esteem. This is also called grandiosity. You need the decreased need for sleep, um, feeling rested after only about 3 hours or less, being more talkative than usual, or kind of feeling pressured to keep talking, having flight of ideas. So these are kind of like racing thoughts. Also being very distractible. So attention can easily be drawn to something else or something unimportant. And then there's this increase in goal-directed activity. It can be social activities, things related to schoolwork, sexual activity often. Online activity is a big one for kids nowadays. Or instead of just increasing goal activity, it could be psychomotor agitation. So this could be maybe not so goal directed, but it just seems kind of like purposeless. They just can't, they have to move. And then another possible symptom is involvement in activities that have kind of a high potential for painful consequences. So this is risk taking. And you might think of this as like online buying sprees, a lot of sexual indiscretions, especially if the child wasn't sexually very indiscreet before, or sudden involvement in things like online gambling or other kinds of foolish investments of whatever money that they have. I've talked to teens who have planned out a whole business plan, and sometimes the plans are actually pretty good because they're very intelligent, but they don't understand that as a 16-year-old they're not going to be able to implement this plan. Of course, the disturbance has to be severe enough to cause marked impairment in social or school functioning, or to have required hospitalization in order to prevent harm to the self or to others. Or if there are psychotic features with the episode, then this is, by definition, a manic episode and not a hypomanic episode. And of course, it can't have been because of substances or another medical condition. So if they've been doing meth for 3 weeks and it looks like they've been manic, that is not a manic episode. That's substance abuse. So some pointers for mania in kids is that in kids and teens, an irritable mood can often be the main feature. Sometimes instead of, or kind of alongside, some elevated or expansiveness. So grandiosity might look like unrealistic beliefs about their abilities or special powers, but especially in younger kids, how can you distinguish this from normal kind of childhood fantasy play? Another thing about risky behaviors in youth is that, like, especially during adolescence, there's often risky behavior. So if they're sneaking out of the house at night, every now and then, is that really, you know, abnormal risky behaviors? If they start experimenting with substances, is that abnormal risky behaviors? If they're driving recklessly, is that abnormal for adolescents? Really, the severity of these things have to be taken into account, and the frequency, in order to determine whether or not it's associated with like mania or not. So there has to be kind of a clear and observable change from the child's usual behaviors and functioning. Now I'm going to talk about bipolar 2 disorder, which instead of being characterized by a manic episode with or without a depressive episode, you have to have a hypomanic episode and a depressive episode. So what is a hypomanic episode? So hypomanic episode is a distinct period of abnormally and persistently elevated expansive or irritable mood and abnormally and persistently increased activity or energy. And these last at least 4 days and is present most of the day, nearly every day. And of those manic symptoms that I listed before, for hypomania, there need to be at least 3 or more of those symptoms. But you need 4 if the primary mood is actually irritable and not kind of grandiose or expansive. And these symptoms need to be a distinct change from usual behavior. They also need to have been observable by others and not just self-reported. So if someone self-reports that they've changed and the parents are like, no, they're kind of normal, that you can't give the diagnosis. And for hypomania, the episode is not severe enough to have caused like marked impairment usually in like social or occupational functioning. In fact, a lot of times hypomanic episodes result in improvement in functioning in some ways, at least getting more stuff done. And also hypomania can't be because, I started pounding monsters or something like that. It can't be associated with a substance or some other medical condition. So some pediatric pointers for hypomania include that the mood elevation is less dramatic than in mania, but noticeable. And sometimes the family might even see this as a positive change because there's this increased energy, there's more productivity, they may be more creative, more willing to try new things, especially if the mood is elevated and not irritable. To distinguish it from periods of high energy, enthusiasm, or typical adolescent moodiness really requires a careful look at whether or not there's a distinct change from baseline, and the whole clustering of symptoms, and also the duration criterion. I'm also going to quickly just touch on cyclothymic disorder here. It's one that I don't think gets diagnosed that much, that at least not in my practice, but I've seen it diagnosed before, and it may be useful to describe some mood disorders and pediatric mood disorders. So there have to have been mood disturbances that are fluctuating for at least 1 year in children and 2 years in adults. And there are numerous periods with like hypomanic symptoms, but they don't meet the full criteria for a hypomanic episode. And there are also numerous periods with depressive symptoms that don't meet the full criteria for a major depressive episode. And during that 1 year period, these kind of hypomanic and depressive periods have been present for at least half of the time and have not been absent for more than 2 months at a time. Also, if you've ever met criteria for major depressive disorder, if you've ever met criteria for a manic episode or a full hypomanic episode, then you don't qualify for cyclothymic disorder. Now, it may be useful too, when you're talking about mood disorders or specifically bipolar spectrum disorders, to use the other specified bipolar related disorder. So this category is used when symptoms of bipolar disorder cause clinically significant distress or impairment, but they don't quite meet the full criteria for bipolar 1, bipolar 2, and they don't meet criteria for cyclothymic disorder. So this is particularly relevant when presentations are atypical, hard to describe, or kind of subthreshold, or you could say prodromal, like they're building up but not quite there yet. So you might think of things like short duration hypomanic episodes, like 2 or 3 days instead of 4, but there has been a major depressive episode. So they have the major depressive episode, not quite hypomanic episodes, but they have something like it. So you could call this some other specified bipolar disorder. So this allows clinicians to recognize and address impairing bipolar-like symptoms that might otherwise either go undiagnosed or just ignored. So some use with these presentations might actually benefit from treatment for bipolar disorder instead of treatment for just major depressive disorder. The DSM also has some specifiers for bipolar disorders. So there's with or without psychotic features. So if delusions or hallucinations are present, not just like general kind of grandiosity, but really, kind of delusional type of grandiosity is often very common. There can also be mixed features, and so this is probably underdiagnosed. This applies when there are at least 3 symptoms of the opposite mood pole present during a current manic, hypomanic, or major depressive episode. So there's mixed symptoms. So for example, a major depressive episode with mixed features might include irritability, which can be common in both, but also racing thoughts, or distinct periods of elevated mood within a day, or for a couple days that then crash back down, or kind of like hypomanic looking periods within a major depressive episode. There's also a specifier for rapid cycling. So this is for individuals who've had at least 4 mood episodes in the previous 12 months. So those can be manic, hypomanic, or major depressive episodes. And the episodes are separated by at least 2 months of remission or a switch to the opposite polarity. So you can go from manic to depressed to manic to depressed, and there has been at least 4 distinct episodes in the previous 12 months. This can be confusing sometimes when you're sitting down and trying to like make a timeline out of things. There's also with anxious distress. So this is used when at least two significant anxiety symptoms are present, like feeling really tense or feeling very restless when you have a depressive episode, or being very worried about what's going to happen in the future, or what other people are thinking about you beyond just like the typical depressive rumination. And then you can specify whether things are mild, moderate, or severe. That's a little bit more subjective and really kind of based on functional impairment or number of symptoms. So you can use rating scales to diagnose mild, moderate, severe. And I think that's a pretty clinically useful way to do that because you can track whether or not it's improving with scales. You can see if something was severe but now still present but mild. And so you say, you know what, you still meet diagnostic criteria, but what we're doing seems to be improving your prognosis. And before I jump into some of the history of the diagnosis of bipolar disorder, I want to mention that it is very important to get this right, especially in kids, because the medications that we use for bipolar disorder are often kind of heavy hitters. We use antipsychotic medications and mood stabilizers, and some of these have lots of potential side effects, or when they're used in the long term, will have bad side effects. So we're talking about, for the treatment of bipolar mania and for maintenance therapy, lithium; for the treatment of acute mania alone, valproate, carbamazepine, and even lamotrigine. Although lamotrigine in studies tends to be more effective for the depressive phases and would take a long time to be effective for a manic phase, if at all. With the antipsychotics, and these are often used because they tend to dampen down mania, and it sometimes can have a little bit of effect on the depressive phases. We have things like aripiprazole, acinapine, olanzapine, quetiapine, and risperidone. Now, there are a lot of other treatments that could be given, medication treatments for kids with bipolar disorders. There's drugs like lorazepam, the combination of olanzapine and fluoxetine, especially for bipolar depression. These haven't been FDA approved in pediatric populations, but there's some evidence of efficacy, and some providers will use these. But now let's take a look back into the past. I think it's important to discuss the history of diagnosing pediatric bipolar disorder, because if you follow some of the history, you'll understand why what you're doing right now is so fraught and difficult, and that you should be paying attention to what you're doing when you're diagnosing pediatric bipolar disorder and not just checkboxing criteria. So to really understand the current landscape of pediatric bipolar diagnosis, we need to take a trip back in time. So the concepts of mania and melancholy, they're really not new. Physicians all the way back to the likes of like Hippocrates and Aretaeus of Cappadocia, they were writing about these depressive and manic symptoms a long, long time ago. But generally in Western cultures, these were seen as separate conditions, and some people had both. But a big shift came in the mid-19th century when the French psychiatrist Jean-Pierre Faure, if that's how you say it, described folie circulaire, so circular insanity, or kind of a revolving insanity. So think manic followed by depressive episodes in a single disorder. Then probably one of the most famous psychiatrists of all time, Emile Kraepelin, around the turn of the century, the 20th century, identified various affective disorders under the umbrella manic depressive insanities. The early DSM version used broad terms like manic depressive illness. This was in DSM 1 and 2. In one, it was called manic depressive insanity. But the term bipolar disorder with more modern diagnostic criteria first appeared in the DSM 3 in 1980. But here's the kicker. Throughout most of history, these diagnoses were rarely ever applied to children, but sometimes to adolescents. It seemed easier to first apply depressive illnesses to kids, but not so easy to apply our ideas of what a manic episode was to kids. So mood issues with youth instead were often seen as kind of either development or mental turmoil, some sort of behavioral problems, some conduct disorders, criminality, but not bipolar disorder as we understand it in adults. But then there was this major transformation, and this is in the late 20th century and the early 21st century. So we're talking about later in the 80s and into the 90s and early 2000s, where there's this realization that really bipolar disorder could manifest in childhood and early adolescence, and that it could look different than in adults. So this was partly fueled by adults with bipolar disorder reporting that their symptoms actually started way back in the day when they were young kids. They remember having something going on that was different than other kids. So this period saw a dramatic increase in pediatric bipolar diagnoses, both in outpatient and inpatient settings. So there's reports that mentioned like a 500% increase in the decade before DSM-5 came out in 2013. So this surge was influenced a lot by this research suggesting that pediatric bipolar in youth might present more chronically, or it might have super fast mood cycling, even multiple mood shifts in a single day. And this was called ultradian cycling. Or it could have severe persistent irritability as a core feature, rather than the classic euphoria seen in adults. So this evolving understanding contributed to way more kids being identified with pediatric bipolar disorder. You could say there was almost an epidemic of pediatric bipolar disorder, and likely a way overdiagnosis of pediatric bipolar disorder. But pediatric bipolar disorder isn't just about kind of psychiatry discovering a condition that was always there. It's really a more complex story than that, involving how we make clinical observations, how we interpret research, how we change paradigms. So in bipolar disorder, there was this initial kind of under-recognition, followed by a rapid spike in diagnoses, suggesting really that the diagnostic goalposts themselves changed rapidly and significantly. Also, the estimates of the prevalence of bipolar really depend on who you talk to. So some people estimate as high as 5% of the pediatric population has bipolar disorder, others 0.1%. So it really depends on who you ask and what their criteria are. There were different efforts to redefine pediatric bipolar disorder. Some of them insisted on applying the strict application of adult DSM criteria. Let's stick to the rule book. Others emphasized sort of the cardinal manic symptoms and rapid cycling. So this highlighted that you have these core manic symptoms like euphoria and grandiosity, but you can also allow for them to be very brief, and there are rapid mood cycles instead of these distinct longer periods. So this is the idea of the ultradian cycling I mentioned before. And this isn't really typical in adults. But for some researchers, they suggest that bipolar disorder in kids can look like this. Other people, especially a researcher named Barbara Geller, who published some studies following kids through time, applying diagnostic criteria like this, and then looking at the morbidity through time. They were able to demonstrate that if you apply these criteria, that you will be capturing kids who have highly morbid conditions. Why not just call this bipolar disorder? But then there were others who really emphasized kind of the severe irritability and the allowance of a really kind of a broad phenotypic picture for pediatric bipolars. So this included researchers like Ellen Leibenluft and Joseph Biderman, and it attempted to capture kids with more severe chronic kind of non-episodic irritability and explosive temper outbursts, thinking that these could be the primary manifestations of mania in children, even in the absence of the classic euphoric or grandiose episodes. So these different kinds of views, especially the idea of the chronic irritability and temper tantrums, being enough to diagnose pediatric bipolar became a huge point of controversy, and this broadening of the diagnostic criteria by some was obviously a key factor in the increase in the number of pediatric bipolar diagnoses. The more sensitive your criteria, the more often you're going to be diagnosing something. And then this whole debate over the irritability and episodicity of bipolar disorder really set the stage for the introduction of disruptive mood dysregulation disorder into the DSM-5. So there's a recognition that all of these different syndromes, if you want to call them that, have a high level of morbidity and they need to be recognized. But should they all be recognized under the pediatric bipolar spectrum, or is there differences between them? Can we call some of these things disruptive mood dysregulation disorder? So this highlights the fundamental challenge in child psychopathology. Like, how do you tell, for example, a mental illness apart from more just extreme forms of normal development, especially when the symptoms really aren't the classic adult ones, which is common in most diagnoses you can apply to both adults and kids. So the initial reluctance to diagnosing pediatric bipolar disorder in kids might have stemmed from this inability to really define how it manifests in children. For example, distinguishing clinical grandiosity from just normal childhood fantasy, or manipulation from, like a really happy kid or a kid with ADHD. It can be tough. But then as diagnostic ideas broadened to include less specific symptoms like severe irritability, which is in a lot of things, anxiety disorders, which are super common in kids, depressive disorders, which are also very common, this risks misinterpreting normal variations or variations of other conditions as pediatric bipolar disorder. So this brings me to the relationship between pediatric bipolar disorder and disruptive mood dysregulation disorder. So disruptive mood dysregulation disorder was introduced in DSM-5 in 2013 to address the widespread concerns about the overdiagnosis of pediatric bipolar disorder in children and adolescents. Specifically, it was meant for the kids with those chronic, severe, non-episodic irritability and the frequent temper outbursts, rather than those kids with like distinct episodes of mood elevations, mania, or hypomania, which most people can agree is bipolar disorder. So maybe DMDD will give us a more accurate diagnosis for severely irritable kids and separate them out from the true pediatric bipolar disorder kids. Some disagree. But DMDD itself is characterized by severe recurrent temper tantrums, and they're grossly out of proportion to the situation. They're inconsistent with the kid's developmental level. They happen 3 or more times a week. And the mood between the outbursts is persistently irritable or angry most of the day, nearly every day. And everybody can tell. Also, the symptoms have to be present for at least a year, and there is no period of 3 or more consecutive months without these symptoms. They also have to be present in at least 2 settings, not just at home, which suggests more psychosocial problems. Shouldn't make the diagnosis the first time before the age of 6 or after the age of 18. And symptoms, either by history or observation, have to have had an onset before the age of 10. And here's really the critical thing, that there's never been a distinct period lasting more than a day where the full symptom criteria, except duration, for manic or hypomanic episodes have been met. The behavior also can't occur only during a major depressive episode, and can't be better explained by another disorder like autism, PTSD, some sort of anxiety disorder. So to summarize, the creation of DMDD was a big move to try to curb the diagnostic expansion of pediatric bipolar. But as often happens, the new diagnosis brought its own set of problems. Some people have questioned its clinical validity, how well it can be differentiated from things like ODD, and whether the evidence base for its inclusion was really even strong enough to begin with. Trying to solve one problem, DSM-5 might have just created some new problems and headaches for us. And how do you treat DMDD? Do you treat it like bipolar disorder? A lot of kids I've seen who've come to me with a diagnosis of DMDD have been put on mood stabilizers or antipsychotics. Others seem to have responded to SSRIs or just therapy. So let me review how to differentiate manic or hypomanic episodes from DMDD. First is the episodicity. How episodic is it? That's really the big one. Pediatric bipolar involves distinct mood episodes that are clear. They change from baseline. DMD is chronic, pervasive irritability at baseline. It's there most of the day, nearly every day, even between the huge temper outbursts. Pediatric bipolar comes with a cluster of other symptoms like grandiosity, decreased need for sleep, pressured speech, racing thoughts, increased goal-directed activity, risky behaviors, but none of these are core features of DMDD. And in some cases, people argue, well, in kids, especially the younger ones, how would you measure this stuff anyway? Now, the nature of irritability might be different in pediatric bipolar disorder and DMDD. So irritability in an episodic disease should be part of the broader syndrome of the elevated mood and its energy. So it should be episodic, whereas in DMDD, the irritability should be a main persistent mood state. And of course, like if you've ever had a hypomanic or manic episode, you have to diagnose a bipolar disorder. Now that I've talked about pediatric bipolar disorder and DMDD, there's also some other tangled webs of differential diagnoses and comorbidities with things like Autism Spectrum Disorder and ADHD and trauma disorders and anxiety disorders and ODD. So let's talk a little bit about that. Let's start with ADHD. There's huge overlap. There's hyperactivity, there's increased energy, there's distractibility, there's poor concentration, there's impulsivity, there's irritability, there's low frustration tolerance, mood lability, being very talkative, sleep problems in both. Wow, that's a lot of overlap, right? The distinguishing feature then is the episodicity, if you want to have a clear idea of whether or not there is a manic episode. Pediatric bipolar's core symptoms are a clear change from baseline. ADHD symptoms are typically chronic, pervasive, and really there from an early age. Although you can have exacerbated ADHD symptoms with psychosocial stress. So if the exacerbation is only related to psychosocial stress, then it's probably not episodic, in the same way that pediatric bipolar is episodic. There's also no really core manic features like elation and euphoria. If there's like clear grandiosity, this is not typical of kids with ADHD. Now, kids with ADHD can be really excitable. They can get really kind of hyper-focused and start and stop different projects, but it's usually not associated with this extremely elevated mood and decreased need for sleep. So kids with ADHD often have trouble sleeping, have trouble winding down at night, will sleep kind of erratically, but they still need sleep and they'll be kind of sleepy, irritable, and exhausted during the day. They'll feel less energy when they don't sleep well, whereas the kids with pediatric bipolar won't experience that loss of energy. It can also be hard to think about the difference between like racing thoughts and flights of ideas. Now, ADHD is often involved in emotional ability, with irritability, a low frustration tolerance. But pediatric bipolar mood swings are usually very severe. They're sustained for longer, and kind of a more profound departure from baseline than what you would see in ADHD. And also, if there are any psychotic symptoms, this is not a feature of ADHD unless they have been put on higher dose stimulants, and then this can cause some psychotic symptoms. And so if you have them on stimulants and you reduce the dose or take them off those stimulants because they started to have report some strange perceptual experiences, and those go away, that's more likely the medication induced. But if they have psychotic symptoms outside of that, then that's not ADHD. That's more likely bipolar. And then with family history, this is interesting because a lot of people I've seen, they hear bipolar in the family member and they're like, oh, then you have a very high chance of having bipolar disorder. But that's not true. If you have bipolar in a family member, you have a high chance of having major depressive disorder. If you have a lot of ADHD in the family, you do have a high chance of having ADHD. It's far more heritable than bipolar disorder. So if you're thinking in terms of heritability, if you see a lot of ADHD and some bipolar, the ADHD is more likely to be heritable than the bipolar disorder. But they can also be comorbid. You can have ADHD with pediatric bipolar disorder. And then there's been some studies that say like 60 to 90% of youth with pediatric bipolar disorder also meet criteria for ADHD. So if the ADHD symptoms kind of are pervasive and stick around even when the mood has been stabilized, both diagnoses can be made and both can be treated. And you can treat ADHD with stimulants in kids with bipolar once you have stabilized the mood. So this is more advanced stuff, but it can be done. Now let's talk about pediatric bipolar disorder and autism spectrum disorder. This one can also be really tricky, and I've had one patient who had autism spectrum disorder and manic features, but it was really hard to tell if they were manic features or if they were agitated catatonic features. Even now, I'm not sure which they were. And it's important to distinguish those two because you treat catatonic features generally with benzodiazepines and you treat manic features generally with mood stabilizers, and you can even use antipsychotics, but you don't want to use antipsychotics in kids with catatonia because that can worsen the catatonia and greatly increase their risks of having malignant catatonia. So this is a big problem. Are they regressing in autism? Are they having autism like catatonia? Or is this bipolar? So there's a lot of symptom overlap. You could have irritability, agitation, severe temper outbursts, and then it's combined with the social and communication difficulties. So you can have repetitive speech in autism, in catatonic autism. It can become worse. You can have like pacing or things like stimming in autism spectrum disorder, which can increase sometimes and might be seen as maybe a manic feature, pressured speech, versus things like that idiosyncratic info dumping in autism spectrum disorder, where they just like get excited about something and have to tell you everything about it. And then this sort of intense focus or preoccupation with certain things, maybe a brand new interest might look very manic, like very goal directed, and at times maybe even grandiose if they think that they've figured out something, something important for the world. And then, of course, sleep disturbance is very common in autism or autism with catatonia, and also in autism with a lot of anxiety. So, it's a hard question. But if you can see that there's a change from baseline and that this is an episodic change from the core features of autism spectrum disorder, then that's more likely pediatric bipolar or a more intermittent type catatonic picture. So then you have to distinguish between those two things. If you're thinking about social deficits, an autism spectrum disorder, a core diagnostic feature and a baseline feature for most is a certain level of social deficits. But in pediatric bipolar, social functioning might worsen during episodes and potentially like completely tank. But social functioning also can tank during catatonic episodes. One thing that might help is if you can demonstrate that there's contextuality to some of these symptoms, especially irritability or the meltdowns, because in autism spectrum disorder, these are often triggered by some sort of sensory issue, something that doesn't bother us at all, that we wouldn't even predict would bother someone, but is really bothering them, or changes in the routine, frustrations with trying to communicate, especially in new situations, which is kind of this social overload where they just kind of reached the limit of what they can handle. But in pediatric bipolar, the mania or irritability is probably part of a broader syndrome. Although it can be difficult because you can always sort of, in a facilitated communication type way, try to point to things within a person with autism spectrum disorders environment that you think are exacerbating them, when in fact it's more internally driven by a mood disorder. So it's very hard, and you have to think about it a lot and go over all the possibilities. It's not an easy question. But it's also not an easy question, what are trauma-related symptoms in pediatrics versus pediatric bipolar? Because trauma-related symptoms can also be kind of episodic. They were triggered, you say. So there's a lot of symptom overlap. Both pediatric bipolar disorder and complex PTSD and what some people call like cluster B traits in personality pathology can involve things like mood swings, irritability, anger, aggression, hyperarousal, irregular sleep, concentration difficulties, risky behaviors. Now, in a trauma-related disorder, the one thing you have to have is trauma. If you don't have a trauma, then it's not a trauma-related disorder. But you don't always know in kids you don't know what they've experienced and they can't always tell you. So you can't just immediately rule it out because there's no expressed history of trauma. Now, if there are distinct euphoric mood episodes, kind of this grandiosity or the racing thoughts and pressured speech, and a very clear decreased need for sleep away from baseline, that's more like pediatric bipolar. So those core manic symptoms are there and they're episodic. The things that would be more episodic in PTSD are things like worsening of their hypervigilance, some of the negative cognitions, especially if they're experiencing some sort of like triggering situation, some impulsive behaviors and risk-taking behaviors in PTSD as well. There could be some overlap in what people say are psychotic features, which would be typical of a manic episode, or at least defining a manic episode. Things like re-experiencing the trauma, flashbacks, nightmares related to the trauma, or things like hypnagogic and hypnopompic hallucinations, where when they're going to sleep or waking up from sleep, that's less likely to be due to mania as it is to just be due to a physiological process. And if that's complicated by trauma, then you can have some pretty intense experiences related to that. So it's important to get a good characterization of what they're saying is a psychotic episode. I've seen dozens of kids have come to me with a diagnosis of MDD with psychotic features because they asked them, do you hear things or see things that aren't there? And they're like, yeah, I see shadows. And yeah, I kind of sometimes hear people calling my name. And someone puts the psychotic features label on them. And when I go in and I ask a whole bunch of questions, I can't find anything that's psychotic about them whatsoever. So be very careful about that. Also, nature of sleep disturbance will be different. A person with PTSD, they will often, especially when they're being triggered or hyper vigilant, or their anxiety spikes, they'll have more difficulty with sleep. They'll wake up a lot. But during the day, even though they might say that they're not feeling tired, they're still exhausted. And that hyper vigilance is kind of driving them. Whereas with the nature of sleep disturbance in mania or hypomania is a decreased need for sleep and they don't even feel tired. And it's episodic. But there's also the comorbidity problem. So childhood trauma is a significant risk factor for pediatric bipolar disorder. It could lead to earlier onset pediatric bipolar disorder, more severe illness course, and potentially even a longer period of untreated bipolar disorder because it's missed, because everyone's just calling this what happens to a kid who's been traumatized and neglected. But they frequently co-occur. And then the last co-occurrence I want to just hit on real quick is pediatric bipolar and oppositional defiant disorder, or other kind of disruptive behavioral issues. So the overlapping symptoms here are that chronic irritability, that very, very non-specific irritability that we've talked about, the anger, argumentativeness, defiance, temper outbursts, and these are really classic of ODD. But they can also be a feature of pediatric bipolar, especially during irritable manic or kind of mixed episodes, or in the depressive episodes where irritability is the main part of the mood. So the thing that would distinguish ODD from pediatric bipolar is, again, the episodicity. Is it episodic? Pediatric bipolar is episodic. There is a clear and significant change from baseline. ODD, like DMDD, is more persistent. There's this pervasive pattern of negative, hostile, and defiant behaviors. But they don't meet the criteria for DMDD. There's also this kind of really context dependence in the behaviors with ODD that could also be there for some of the worsening or exacerbations of bipolar disorder symptoms, but the bipolar disorder symptoms would be there even without this context. So ODD is like primarily a style of interacting with authority figures. And so if it's more just in that context, then that points more to ODD. And like I said, you can only diagnose ODD if you've ruled out or there are no features of pediatric bipolar disorder and they've never met criteria for DMDD. As a final sort of like shoot off, and don't miss this, and as the anxiety disorders, and I'm going to be covering those in future episodes. But anxiety disorders are the most common disorders in children, and they are also by proxy super common in pediatric bipolar, especially for the teens, but even the younger kids sometimes. Substance use, it's a big deal. It might be something that's been hidden for a very long time. So all this massive overlap and comorbidity, it really means that diagnosing pediatric bipolar disorder is never simple. It's a careful process of ruling other things in or out. You need a sophisticated understanding of their developmental stage. You need to gather information from multiple sources, the child, parents, even siblings, teachers. And then sometimes you just have to watch things over time. When things are not clear, you just have to be diligent and track things over time. Clarify patterns. See if things really are episodic or more continuous. So I'm going to end with one more case vignette. So this is about Ethan. He's a 16-year-old male with a long-standing diagnosis of autism spectrum disorder. He's also had a diagnosis of generalized anxiety disorder. He's always had significant kind of social problems, limited eye contact, these intense narrow interests. Currently, he's like obsessed with ancient Roman military tactics. So his parents are bringing him in for an evaluation due to more recent kind of unusual changes over the past 2 weeks. So Ethan, who's typically quiet, prefers solitary activities, has become a lot more talkative. His speech is somewhat more tangential than it was before, but then kind of returns back to this one focus of special interest. So it wanders off more than it did, but he pulls it back. He also claims to have cracked this code of Roman ancient battle strategies and kind of believes, he could advise modern militaries on how to do things. So he's spent hours online actually trying to contact defense officials. He's gone to websites, official government websites, and sent some messages. Now, he's been sleeping 4 to 5 hours per night, but he used to get somewhere between 8 and 9. He often appears more energetic, and he's pacing a lot more than he used to, and kind of talking to himself. He used to do this, but like now he's doing it quite a bit more. And when parents are trying to redirect him, say for example, away from his computer, or suggest that like maybe he's, this isn't very realistic, is more snappy and irritable, which is kind of a change from his more kind of passive compliant stance that he had before, or that he would just like not respond. He also seems oddly less bothered by some of the sensory sensitivities that used to distress him. And his parents note that like about 3 months ago, he had a 3-week period where he was unusually tearful, expressed feelings of hopelessness about his future, and he refused to engage in his interests. And this was really atypical for him, but because it, resolved, they hadn't really thought about it until now. When you ask them how long this has been going on for, they say it's been about like a week, maybe longer. They're not quite sure. So which of the following diagnostic considerations best account for Ethan's recent changes? Is this just an exacerbation of his autism spectrum disorder symptoms, or what we call a regression? Is this obsessive compulsive disorder? Is this pediatric bipolar 2 disorder with a current episode hypomanic? Or is this schizophrenia in an early kind of prodromal manifestation? So the correct answer here, and I think most of you probably have guessed this already, is pediatric bipolar 2 disorder. Now, while this could be just an exacerbation of his autism spectrum disorder symptoms, this increase in intense focus on something, being kind of tangential, all this pacing and stuff, most of what they describe kind of looks like what it did before. But there's also this added kind of grandiosity that he didn't have before, and he is more irritable than he was before. And then there's this increased need to talk about it, and even though he used to do that, like it is increased from his baseline. There also is evidence of a recent depressive episode, which means that his moods are episodic. There are some features of obsessive compulsive symptoms in here. So especially as kind of this intense focus on one thing and needing to think about it and needing to do something about it. But the accompanying kind of elevated mood, along with this decreased need for sleep, some of the grandiosity, the pressured speech, they're not really OCD symptoms. So OCD is more like the obsessions and some sort of compulsion to reduce that anxiety. And that's not a primary feature here described in this context. Now, this could be prodromal part of schizophrenia or a schizoaffective disorder, but we don't know that based on what we were given. So, and the core features of schizophrenia are not here. His speech, while tangential, is not like grossly disorganized. So, I wouldn't call this schizophrenia. Well, thank you for hanging out with me today. I hope this episode was helpful. It's one of the longer ones, and I felt like it needed to be very long because of how fraught the diagnosis of pediatric bipolar disorder is. What an intense sort of history it has of change within the last 30 years of how we understand pediatric bipolar disorder, and getting the diagnosis is crucial because you're talking about choosing between giving kids things like antidepressants or anti-anxiety medication, or giving them mood stabilizers or antipsychotics, versus maybe for catatonic features the need to give them benzodiazepines. So the treatments for things that look like pediatric bipolar disorder can be very different than pediatric bipolar disorder. So it's very important to know what you're dealing with. Thank you for hanging out today. This has been an episode of PsyDactic and an episode of PsyDactic Child and Adolescent Psychiatry Edition. Until next time, I'm Dr. O'Leary. Take care of yourselves.